Hello and welcome everybody. Today we have a wonderful day of programming for you. We will be getting started by learning from Sarah, who will be teaching you about neuropalliative care.
Thank you, Emma. I'm going to go ahead and share my screen. Perfect. So, good afternoon, everyone. My name is Sarah Francis, and I'm a teaching fellow with the Accomplished program. I also just started my medical degree at McGill University in Montreal, Canada. I'm in my second semester, and prior to this, I completed my master's of public health. So, I have no disclosures. So, today we're going to be talking about neuropalliative care, and here are a few of the different learning objectives for our session. So first is understanding the core elements and the variations of palliative care and neuropalliative care, recognizing populations that can be supported by palliative care, and also specifically neuropalliative care, learning about the individuals involved in neuropalliative care planning and the benefits to healthcare systems, and finally identifying the ways in which palliative and neuropalliative care can improve patients' and even families' quality of life. And here's a brief outline. So we'll have a clinical case. We'll go through what palliative care actually means, do some myth busting, and then look at some examples and approaches that are used in this type of care and how it can impact healthcare systems and what can you do if this is something you're interested in either learning more about, or getting involved in. So first we have our clinical case. So would anyone like to read this clinical case? Perfect. I see Naomi, you have your hand up. Go ahead.
Maria, a 60-year-old woman, has advanced lung cancer with metastasis. She experienced severe pain, shortness of breath, and anxiety about her prognosis. Her family is struggling to cope and feels unsure how to help her. Maria's children work long hours and have children of their own, making the situation even more difficult.
Perfect. Thank you so much, Naomi. So here we have our case. Are there any words within our case that stand out to you? It could be symptoms, it could be a particular circumstance for Maria. You can either raise your hand or you can also type them in the chat. I'll get the chat out here so I can see. So I see severe pain, metastasis, exactly. So does everyone know what metastasis is? So I see some no's, and this is a word, and I see some cancer spreads throughout the body. Exactly. So cancer will typically start in one area of the body. And then when it's called, you'll have your cancer in situ, which just means in a particular area. And there's a part of the cell that's called a basement membrane. This is getting more into the biology of it. But once the cancer cells will cross that basement membrane, they start to infiltrate other parts of the body. And that's when you can say that your cancer is metastasizing. It means it's spreading. And so this can become dangerous because rather than just impact, let's say, the lungs or for breast cancer, the breast in that case, it's going to be impacting different parts of the body. Perfect. So are there any other parts of this case here that stood out to you? So I see cancer cells, shortness of breath. Perfect. So you got pretty much all those key words, and we'll continue and we'll look at rhyme here. So this is typically when we have our case, we'll go through this protocol to catch all the important details and to determine what should be done next and even how could we prevent it. So R is for record. So that's signs and symptoms. So what you all were doing just by pointing out those specific indications. So here we would have severe pain, shortness of breath, and then we would also have anxiety about her prognosis. But something else in this case that's important to note is that we're not just looking at Maria. We also get information about her family and her children. And so because her children have children themselves, it makes the situation difficult here because they're not able to be primary caregivers and can't give all their time in order to help their mother in this case. And then we have our I for interpret, creating a differential diagnosis, M for managing and treating. So that'll be looking at the important details here and deciding what the next best course of action would be. And finally, educating. So that's where you all come in as health liaisons, taking information, which we'll learn throughout the presentation, and sharing with family members, sharing with friends that could pass this message on and just understand more about what neuropalliative care might be. So before we move on, any questions so far, anything about the case or anything that I've mentioned since the beginning? Perfect. Well, if there, oh yes, Jalen, I see you have your hand up.
Okay, I have a question.
Yes.
So, can you like explain? So, you said that I don't know how to say the word, the metastasis is like something
Yeah.
like it spreads throughout the body. So, why in the case did you include that it's like an advanced lung cancer and not just metastasis?
Yeah, so that's a really good question. So the advanced lung cancer is really the primary diagnosis in this case. So Maria, say, has been at the hospital, spoke to an oncologist, and discovered that she has advanced lung cancer. But the thing with the advanced part of the lung cancer means that it can become so aggressive that it can also spread to the rest of the body. So that's why both were included. If it was just advanced lung cancer, that could be, depending on the treatment options, there could be a more positive prognosis. But with the metastasis, the prognosis becomes slightly poorer because it starts spreading and the cancer is less predictable in the body. And feel free at any point, if you do have other questions, type them in the chat or just raise your hand and we can always pause. So these are some other questions to consider in the case. So what are the most pressing concerns? Who are the parties affected? And what might offer relief in the short and long term? So sometimes, especially in palliative care, it's not just about what will offer relief right now. It's thinking about if the patient has a disease condition that might last more than 3 months, you have to think about how to offer relief in that time frame as well. So now we'll go through palliative care. So if we break down the word, palliate comes from pallium, which means cloak. So to cover up the symptoms of an illness without curing them. So without curing them is really the key part here. And palliative care comes down to helping to alleviate suffering and improve quality of life. So if you retain one thing from this whole presentation and this slide, it's really a focus on improving quality of life, rather than saying this is what we'll do in order to treat the cancer. In certain cases, if it's a serious illness and prognosis, someone only has about 3-4 months to live, it's really about how do we make the last 3-4 months, how do we modify what we're doing in order to alleviate symptoms, improve the quality of life for the patient. So again, here are the goals. So one is comfort, symptom management. So how can we manage symptoms so that the patient is more comfortable in all the therapies that they're going through and on a day-to-day? Communication, having goals of care conversations. So this is really important because palliative care often integrates not just physicians. There are physicians, there could be art therapists involved, occupational therapists, physical therapists. And it's so crucial for those members of a healthcare team to communicate with each other so everyone's on the same page and the patient can receive the best care possible. And finally, coordination. So promoting physical, mental, spiritual, and other needs of family and team members. So like I was saying before, palliative care, depending on what the patient's background and what the patient's needs are, they'll integrate various members. So it's kind of very dependent on the circumstances, and no two patients will look the same in terms of the type of care that they're receiving. Even if they have the same condition, it'll look very different based on their family values, based on their background, and that's what makes it so important to pay attention to those details. So here we see an integrated model. There are a lot of different words that circulate around the realm of palliative care, and so we often hear hospice, bereavement, palliative treatment, curative treatment. So essentially, palliative care really comes in at the diagnosis part. So just because sometimes people will think palliative care just has to be when the patient is at end of life. And that's not always the case. It could be, but we have different terms to define different parts of the prognosis and the patient's trajectory. So if a patient gets diagnosed, say they have cancer, palliative care team will come in early. And that's one of the really important parts they teach us in medical school, is that by bringing in palliative care early on, you can even more help the patient in the long run. So palliative care comes in, and at the point where the illness becomes incurable, so you have a serious illness, it becomes incurable, there's nothing that could be done really to extend the lifespan of the patient, that's where hospice care will come in. And so bereavement is really to provide support to the family members of the patient before, during, and after. In this model, we see it only after death, but it really is this whole encompassing support for the family. And so palliative care can really apply to many different cases. And so I know we're talking specifically about neuropalliative care. So that would be typically we could see with advanced dementia, but some other examples of what it can help for patients are cases such as chronic organ failure, advanced cancer, and any cases really where the patient can request palliative care, and it's typically something that's done with a referral from a primary care physician, or it can be done in a hospital. And as soon as the patient is referred to palliative care, they'll start to receive that support throughout their diagnosis. And so now we're going to focus specifically on neuropalliative care. But before we do that, does anyone have any questions about what we've seen so far, just about palliative care, before we get into the specifics in a little more detailed? Jalen, yes.
Oh, okay, so my question is like, how does that type of care like impact the family and the patient as a whole?
Yeah, really good question. So you can think of it for the patient and for the family. Again, if we go back to our definition, it's all about improving quality of life. So for patients, this could mean helping to manage their pain better. If they have a diagnosis where they have chronic back pain, or maybe they get severe headaches every single day, rather than them going back home, not getting support for it, and then having to come back to the hospital every time they experience it, palliative care makes it so that they have interventions every single day or how often they need in order to just alleviate that pain, and really making sure that it's part of the treatment that they're getting and it's something that's already integrated into their daily life to in turn improve quality of life. So there's many different cases it can help with. Pain is one of the most common ones, and they could also help with managing the different medications that they're taking to make them not have as many side effects as they go through treatment and as they're in the hospital. And for the families, it can help with the burden of caregiving. So for example, if a family is the primary caretaker at home, they could have more support from healthcare teams coming into the home and ensuring that there's psychosocial support for the family if their mental health has been affected by the diagnosis of, let's say, a sibling, a parent, a grandparent, someone in the family. So it really comes down to the condition that we're dealing with and the needs of the family. So some families have experienced that before. They know what to expect and they're able to adapt better than others. But just because if a family has already experienced it, they may experience it again. And that palliative care really is open to any cases. And really, as soon as someone does request it, they're able to honor it in a way that does address those symptoms.
I have another question. Thank you
Yes.
for the explanation. In what conditions does a palliative care not like a situation where the patient can't receive that type of care?
So typically, we're going to think of it as illnesses on a spectrum of severity. So palliative care typically wouldn't come in for something very mild, such as, let's say, a cold or a sore throat, things like that. That is on one side of the spectrum. And then you think of the other side, that would be advanced heart failure. You can think of things like that on two sides of the spectrum. So I would say when you get to the more serious side, that's where palliative care will come in. And it's on a case-by-case basis. But typically, when it's a condition that affects one organ more severely, or the prognosis is poorer or has a potential to become poorer, that's where it'll come in. And I see in the chat here, does it cover the emotional aspect of patients? So if they feel isolated and anxious because of their illness, absolutely. So palliative care does cover for any maybe mental health or anything related to the disease that's more emotional. They will 100% cover that. And so I'll talk a little more about it. But actually, yesterday we have to do a mandatory shadowing of different specialties through medical school. And yesterday we spoke with a palliative care doctor. And she said that typically when patients come in, they ask about their spiritual preferences, religious, things like art. How can they fit those things into the care if it's relevant to the patient to address the emotional component of their illness? So it really, there are so many different ways that it can help the patient and their family. And I see that someone said part of the screen has a border over it. Is it the top part of the screen?
It's kind of like there's boxes all over the screen.
Yeah.
Oh, okay. Let me try something. Thank you for letting me know. I didn't know that. Let's see. Okay. Is this better? Okay. Can you see the whole screen now? Good. Perfect. Okay. So, and let me know if you have any other questions about more of that emotional side, but we'll continue and then we can always come back. So now thinking about neuropalliative care. So the goal here is to alleviate suffering and improve the quality of life for patients and families with serious neurological disorders. So it's important to note here that a lot of different neurological diseases are progressive. So that means that they worsen over time and they don't have a cure. So in a lot of these cases, patients can lose physical, mental capabilities, and this makes them reliant on others for daily activities. So they'll need help to, say, brush their teeth or getting ready in the morning and going about their daily tasks. So importance here of palliative care, neuropalliative care, we see that there's this pain in this big reel. So like I was saying, it doesn't just come down to the disease and how it impacts your body. And let's say you can't move your arm or you have trouble walking. It's really this looking at these 5 different components. So the physical, emotional, social, practical, and spiritual. And this is just they keep adding more. Really, this sphere tries to encompass as many factors as possible, but there are some that aren't included, and it really comes down to the individual patient. But some of the things that get addressed are pain, physical discomfort, financial concerns. So that can be really big, especially if someone's insurance is not covering all of the treatments or all of the different therapies they want to consider. Things like loss of meaning, anxiety, anger, frustration, not really understanding what the disease is, and even just loneliness and isolation. Sometimes patients don't have their family nearby, and so palliative care can help to provide companionship and different methods for ensuring the patient feels less lonely and gets the support they need. So now we'll do a bit of myth busting. Yes, Miriam?
Yeah, I was like, just like a quick question. If the patient doesn't have like any family to take care of them, would palliative care kind of like give them like a caregiver, or would they like refer them to a caregiver instead?
Yeah, that's a really good question. It really depends on the center that they're at, depending on the hospital. In certain hospitals, they're able to connect them with someone who's able to support and who can come in. And that's typically in Montreal, they have that in a lot of the hospitals where, depending on the palliative care needs, they're able to connect with everyone is covered under a certain insurance system. And so they have a different organization who sends people to the hospital to do that. So really, it depends on the hospital that you're in. And I know when I was volunteering in hospice care, when I was living in New York, what they would do there is they had volunteers come in to provide companionship to patients. And so that was one way that they would help alleviate loneliness. But they would also have individuals from different organizations come in for about 5-6 hours during the day, and then they would rotate. So it all depends, and they make sure to work with the patient to find a way that's suitable for them. Then that also doesn't add any financial pressure for having someone come in. All right, so we'll continue with our myth busting. We have a few questions, and you can either raise your hand or you can just type in the chat for these questions. So true or false here? We'll start. Palliative care is only brought in for dying patients. So I see lots of false. Perfect. So false. Palliative care is brought in for anyone. All backgrounds and ages can benefit from palliative care. So it's really important that it's not just for someone who's older. It's not just for someone who's severely, severely ill, and he comes from a particular background. Anyone can benefit. Next one, true or false? Palliative care only supports patients. Perfect. So I see lots of false. And that's correct. So palliative care supports both patients and their families. So it's really a holistic approach to healthcare in a way that addresses not just the needs of the patients, but those around them who are caring for them. Our next one, true or false, palliative care services can be offered outside the hospital. Lots of truths here. Perfect. You're all experts. So this is true. Palliative care services can be offered in different settings, such as hospitals, at home, clinics, and even nursing homes. But it's important to know, and I mentioned this earlier, that to receive these services, patient typically needs a referral from their primary care provider. But you see a lot that palliative care is done in the home, and that could be a part that if a patient's in the hospital and they're saying, I have 4 months, my prognosis is quite poor, I would rather be at home. That would help me be more comfortable. That would improve my quality of life. Then the palliative care team would help them to shift the care they're receiving to their home, if it's possible. If they need complex devices that are only available in the hospital, it might be more difficult, but they're typically able to accommodate, and this can help the family as well, if they're closer. And Naomi, I see you have
would the family be paying for the palliative care, like, still if they're outside of the hospital? Like, would it still count?
That's a good question. This really depends on the insurance model. Typically, even if they're going home, it'll be, unless they need extra things that they would be buying to be at home, typically it'll be covered in the insurance costs, but it's really on a case-to-case basis. And the only reason I would say that maybe it might be more expensive is if they need a specialized, let's say, bed. In certain cases, sometimes they'll get a hospital bed into the home, and sometimes insurance will cover that, sometimes it won't. But I mean, typically the healthcare teams will work with the patient and the family to find ways to minimize costs so that it's not an extra burden on them. So next one, true or false, palliative care cures symptoms of serious or progressive illnesses. So lots of false. Perfect. So again, the key, we eliminate the word cure. We really want to prevent, relieve, treat in short term. So not treat in the sense of cure, and do that for the symptoms of the progressive serious illnesses rather than just curing it. So we're improving quality of life. And so one of the important distinctions here is that not all palliative care is hospice care, but all hospice care is palliative care. So you can think of it, palliative care is this big umbrella, and under the umbrella, you have hospice, you have bereavement care, which we had seen in our previous model. So hospice will typically be in the about 6 months end of life. So that's really when someone discovers that their condition is incurable. That's when they move to hospice care. So here we see the broader picture. We have palliative care, again, this bigger umbrella. You have end of life care, and then finally terminal care. So there's a lot of overlap into all of these, and a lot of it, like we see here, is symptom management, and again here. So that's something that's universally applicable here in these cases. But certain things, end of life care, ongoing medical treatments, once you get to terminal care, the treatments will typically cease, and you'll just focus on psychosocial support for the patient and family and just managing the symptoms. So these are different ways to intervene depending on the condition and depending on the state of the patient and their family members. So now moving into the more clinical side of this and interacting with patients, interacting with their family, how would you deliver bad news to a friend? So say you couldn't make a plan that you had for about 3 weeks before, you were both really excited about it, but then last minute, your mom needs help with something and you have to be there for your family. How would you deliver this bad news to a friend? So you can type in the chat, you can raise your hand, either saying what you would say, strategies you would use, your approach, anything at all. Yeah, so I see start with an apology, be direct and tell them. Apologize and explain. Perfect. So a lot of it comes down to explaining the reason, taking it slow, I like that, and using respectful communication skills. So it's not something that you would just deliver, say, you know what, I can't come, and then move on from it, right? You would take your time, reschedule, trying to find a compromise, giving time. So that's all really important when you're dealing with palliative care and you're dealing with delivering bad news to family members and patients. Now, thinking about the medical sphere, how would you deliver bad news to patients and families? So I see make them comfortable. Take it slow and explain. Yeah. Apologize, giving them space. Empathy, staying calm. Perfect. Exactly. So it's very similar. There in certain ways, it is more, it's heavier of a conversation, of course, in healthcare versus having it with a friend. And you don't always know them to the same level as you know a best friend, right? So it's really important to explaining the situation little bit by bit, like you said here, staying calm. And so there are different ways to, so we're going to, just for the sake of time, we're going to continue here. So we have here, delivering bad news, we have our spikes approach. So setting is the first important one. You want to make sure that you're not doing this in a hallway where there are lots of people around. You want a nice, private, confidential space where they're able to deliver the news in a way that the family can feel comfortable. Perception is important here, delivering it in a way that the family will understand, calm manner. Invitation, making sure that you're doing so in a space, again, that's inviting, in a space that minimizes any discomfort. Knowledge, so one of the important things is to ask the family or the patient what they already know. So you really want to make sure that you're meeting them where they are. By understanding what they already know, you can then fill the gaps and do so in a way that if they say they know nothing about a specific diagnosis, you can really start to explain from the small building blocks of a condition or disease, rather than just giving all the information at once. Emotion, making sure to stay in tune with their emotions, see how they respond, see how they feel. And finally, strategy and summary. Always make sure that you leave with a plan, leave with a way for them to reach you, so that if they have any additional questions, they can be able to get those answered. And ensuring continuity. So checking in on them and making sure that the delivery of this bad news didn't, that you're not just leaving them with the news and then moving on. And then this is also an important acronym, how to respond to emotions. So NURSE is the approach. N is for name the emotion. So that would be identifying what it is, understanding the emotion, respecting the patient, supporting the patient, and exploring the emotion. So it's really important to first pinpoint what it is, and then you can ask more questions to understand how the emotion is affecting them, how they might benefit from support, and what particular support they would need. So how does palliative care improve quality of life? That's through timing of care, a holistic approach, and integrative healthcare teams. So these are some things we've talked about before, but it's really important to bring it in early. So again, you can remember a few things from the presentation. One is that palliative care helps improve quality of life, and it's important to bring it on early, not just when the patient is in a critical state, because by bringing it on early, it can help to prolong the way that the patient is experiencing the illness in a way that's comfortable. Yes, Evia, I see that you have your hand up.
Yeah, hi. Are people who work in palliative care also DOs?
So you can have DOs working in palliative care. There are so many different individuals who are part of it. So here we have this holistic approach and integrative healthcare teams. And if you're a physician, you do a DO or an MD, you typically do a family medicine residency, and then you can specialize in palliative care. But that's just one way of doing it. You can do it in so many different ways, and there's no right or wrong way to move into palliative care. So we can have physicians, nurses, nurse practitioners, physician assistants, social workers, spiritual advisors. The list goes on, even art therapists, if there are patients who could benefit from art, or music therapists if patients want music to alleviate symptoms. So here for advanced directives, the important thing is to write it down, picking someone and planning ahead. So say what medical care that you would or would not want, and this for patients who need to advocate for themselves and explaining what they want when sometimes they get to a point where they wouldn't be able to. Choosing someone trusted to speak for you if you can't, and planning ahead to make sure that everyone knows your wishes. So how can palliative care help healthcare systems? First, it can reduce healthcare costs, and part of this is by decreasing unnecessary hospital admissions and also offering patient-centered care. So it's more efficient, higher quality care that's given to patients. And importantly, in studies, it's been found that those in palliative care actually live longer. So that really reinforces why it's important to bring it in early, because it could really benefit the patient. And finally, what can you do? So first, you can learn and raise awareness, share what you've learned with family and friends, spread awareness about the importance of palliative care. You can also volunteer depending on where you are and depending on the centers around you. Many hospice organizations offer volunteer programs. You can provide bedside company, conversation to end-of-life patients. And finally, don't forget to take care of yourselves, that supporting others, even serious or non-serious illnesses, can be emotionally intense. And it's just as important to take care of your own mental health as you do that. So thank you to the whole accomplished team, and thank you everyone for listening. If you have any further questions, you can reach me here at my email, and I'd be happy to discuss anything.
Thank
I
you
have a
so much,
question.
Sarah, for teaching us all about palliative care and how it plays a role in the medical field in general. Now I will be introducing Valentina, who will teach you about harm reduction. I think Valentina had a small connectivity issue, but while we wait, does anybody have more questions for Sarah?
Oh, sorry, I think my Wi-Fi.
No worries.
Okay. Can you hear me?
Yes.
Okay. So let me know if there's any issues with the Wi-Fi or anything. But like I said, I'll be talking about harm reduction, and I have no disclosures, no disclaimers. Um, and yeah, let me know if you can't see my screen.
We
But I
don't
wanted to
see it.
start with a little warm-up question.
Sorry to interrupt, but we don't see a screen yet.
Okay. Give me 1 second. Okay, I am so sorry. My power went out like 15 minutes ago, so I've been trying now. Can you see my screen?
Yes.
Okay. All right, perfect.
I will be talking about harm reduction. So first I wanted to start with a little warm up. What do you think happens when someone tells a teenager, don't do drugs or don't have sex? Do you think this is an effective way to reduce harm? And you can unmute or let's see.
No.
Not really, no. Miriam, I see you have your hand raised.
I I would say like it depends. Half would probably kind of take it, but half would like make them want to rebel more because they're being denied that.
Yeah, exactly. And you said something very similar to Evangeline, who said either they'll listen or they'll just be more curious about it. So yeah, they'll definitely probably be more curious. Josephine, did you have something to add?
Not only that they're being more curious, but when it's just a blunt statement like that, often without an explanation, they're gonna probably explore it in a way that's not healthy for them.
Yeah, for sure. I completely agree. And Jalen, what do you think? Do teenagers often listen to adults who tell you not to engage in risky behavior?
This is actually really funny because I was literally learning about this in health class like 2 days ago. And my teacher was basically saying like a lot of like southerner states that believe in like abstinence and don't have like sexual education in their schooling, it actually makes them more inclined and they do it dangerously because they don't know about it. So there's like many risk factors, but I feel like in more like Eastern type of things, like New York, like we understand because they have like the sexual education they teach us, so we can like pursue like sexual things like with caution and with safety.
Yeah, that's a great point. And I really like what you said about abstinence, how it's usually ineffective and it leads to higher rates of pregnancy or drug misuse. And that's what I'll kind of be talking about. So, a lot of times when we think of harm reduction, our minds go directly to drugs, alcohol, or sex. But harm reduction is very broad. It's a completely non-judgmental approach that meets people where they are at, treating all individuals with dignity, compassion, and respect. And so harm reduction could mean if it's a really smart student who doesn't want to go to college, then for them, harm reduction might be going to trade school instead, versus for someone else, it could just be taking one or two classes a semester. It's meeting a person where they are at. And even though, for example, Bill Gates, he became a multi-billionaire even without graduating from college. However, we see statistics that say those who do go to college and go to university have a much higher rate of success. And so when we're looking at harm reduction, we're looking at anything that can cause harm or might have some sort of unintended negative question, and then addressing those risky behaviors in a broad audience. And usually we use harm reduction in a healthcare setting, but it doesn't always have to be. And so, usually, when we talk about harm reduction, we try not to promote abstinence because, like Jalen said, it doesn't really work. Especially if you tell teenagers whose prefrontal cortex are still developing, don't do drugs. Okay, but why should I not do drugs? What are the negative effects if I do drugs? That's why harm reduction is so important because it requires explanation and meeting people where they are at. And so it can also refer to sexual behaviors, eating disorders, tobacco use, infectious disease, and even something like washing your hands could be considered harm reduction if you still go out near people. And so here's some more examples. For example, wearing a helmet. We talked about TBIs last week. 41% of motorcycle riders who die don't wear a helmet, versus the chances of a fatality while wearing a helmet are 4.4%. So we know that riding a motorcycle is really dangerous, but we can reduce harm by making people wear a helmet. Also, mask mandates. We wanted people to quarantine, but if they couldn't quarantine during COVID-19, face mask mandates were associated with lower COVID-19 death rates than rates in countries without mandates. So again, harm reduction can refer to infectious diseases. There is also wearing sunscreen. We're not going to tell people, okay, don't go out in the sun. That's unrealistic. However, regular daily use of SPF 30 or higher reduces the chance of developing melanoma by 50%. So instead of saying cover up completely, don't go in the sun, okay, wear sunscreen so you don't get skin cancer. And then also, condoms are a great example of this. Oftentimes, because of religious reasons or cultural reasons, people told kids or teenagers don't have sex. However, now it's become more of a health thing as well. We don't want teenagers who want unintended pregnancies or especially STDs that can lead to cancer or other um, negative effects. So condoms are estimated to be 98% effective at protecting against most STDs, which is why now we say, okay, instead of don't have sex, if you have sex, wear a condom. And that's basically the principle of harm reduction, trying to meet people where they're at. And so basically, we are against drug stigma, coercive treatment, and gatekeeping resources versus a harm reduction approach is non-judgmental, non-coercive, so we don't make people do anything, and provision of services and resources to people who use drugs or engaging in any risky behavior and their communities to reduce harm. And if you help one person, you help their community as well. So basically, if people are going to do a risky behavior anyways, we might as well try to reduce the risk of them getting hurt while doing it. So I wanted to go a little bit into abstinence in schools, and I'm sure you guys have heard of DARE. I don't know if any of you guys did it. Raise your hand if you did DARE or have at least heard of it. And it stands for Drug Abuse Resistance Education. It's taught by, yeah, I see a lot of hands raised. It's taught by police officers in 75% of US school district and reached an estimated 50 million children worldwide. I was taught DARE in schools. This was like in fifth and sixth grade. And funny story, I actually remember being in sixth grade. They had a whole big banner and they were like, sign this to dare not to do drugs. I didn't know what drugs were. But I remember like realizing, oh, they told me not to do it. Well, that's gonna make me want to do it more. So I told myself, okay, I'm not gonna sign it. Even though I had no idea what the negative effects of drugs or anything were, I just was a stubborn little sixth grader who didn't want to listen to what other people were telling me. And so it was found to be ineffective and counterproductive. There was a significantly higher hallucinogen use among the DARE group, and this led to the hypothesis that the program could lead to more curiosity by encouraging abstinence. And so while there were some benefits in urban and rural students, suburban students experienced small but significant increases in drug use after DARE, and any of the decreases in use were shown to go away after a year. And so $170 million were invested by the federal government as well in abstinence-only education, which requires to withhold information on contraception use except for failure rates. Again, this is just causing more harm. And all of the people who took virginity pledges, 6 years later, 88% had initiated vaginal intercourse before marriage. So again, didn't really work. The prevalence of STIs were similar, and pledgers who initiated intercourse mostly failed to protect themselves with condoms and were less likely to be tested for STIs because they didn't know of the harm behind it. So, if you want to raise your hand, what is one reason the DARE program might have increased hallucinogen use in teens? What do you think? Or type in the chat. Rebecca?
I think that one reason the DARE program might have increased this use of hallucinogens might have been because when considering the fact that our minds are underdeveloped as adolescents, we have like this very rebellious phase. So if we're told to do something, we tend to do the opposite. And it's not the same case for everyone, but it is the case for like me and a lot of my friends. But I think that it all depends on how you approach us about it. If you give like strict orders, some people might not respond well to authority. So if you try and meet them in the middle and actually consider what's going on in our minds rather than not remembering how you were as a child, we're most likely going to rebel.
Yeah, that's a great point. And I think part of it, people don't really understand that the way that teenagers' reward system works is very different than the way that an adult reward system works. So, whereas an adult might be driven by money, responsibilities, family, teenagers are very much driven by social situations and a social hierarchy. And so, if they are told, oh, don't do something, they know that they can get, I say they, but I speak for myself as well. You know that you can get some maybe cool points or whatever to do something that you're told not to. And so that's why, along with curiosity, there might be increased hallucinogen use in teens. And then type in the chat, true or false, STI rates were higher for virginity pledgers than for non-pledgers. So yes, it was true from what was shown, but what we also saw was that that people who pledged were less likely to get tested for STIs. So we actually don't really know overall. But from the data we do have, it does seem to be true. And then, does someone want to answer what is the harm reduction approach and how is it different from other approaches in just 1 or 2 sentences? Miriam?
The harm reduction approach is kind of less demanding than other approaches because it doesn't like judge the people who are there, and it treats them with compassion and is kind of showing them, oh, if you do certain like activities or stuff like this, it will can have a negative effect, and it's not telling them completely not to do it. It's kind of showing them if they want to do it, here's a way that you can do it safely, and like kind of showing the effects of it can cause people not to do it, which is like better than other approaches because other approaches are like demanding and it's kind of and it's judging them.
Exactly. That's a really great point. And I like how you said share information, because if someone has all the information, then they can be educated enough to make a decision based on all the facts. But if they don't, they'll be making decisions without all the facts. Um, it's not sustainable. And so from a hospital standpoint, it is not uncommon to see ER wait times of over 2 days. So when we're dealing with complex medical issues, it's helpful when avoidable harms are reduced, such as by wearing masks, social distancing, and getting vaccines. And that way, when a person has a heart attack, a stroke, or other urgent medical condition, hospitals can deal with what's non-preventable in a timely manner. And something that you may not realize, this program right here is harm reduction. When you improve the brain care score of your health liaisons, you are reducing both your risk and their risk of stroke and dementia. And education, like we said, is one of the best ways to reduce harm. And so we can lighten the load on hospitals through harm reduction by preventing future emergencies and educating. And so this paper, Hawk et al. Used data from interviews with 40 patients and staff members from an HIV clinic in the US to describe harm reduction principles for use in a healthcare setting. So first there's humanism, and this is providers value, care for, respect, and dignify patients as individuals. So understanding why a patient makes a decision empowers providers and gives them more background. And this also includes using person-first language instead of saying drug abusers. The correct way to say it would be people who use drugs. And this is a lot more person-centered and humanistic. There's also pragmatism. None of us will achieve perfect health behaviors, and behaviors do not exist in a vacuum. For example, even if you brush your teeth twice a day, at least I'm really bad about flossing every day. And so I know that this is not perfect, but you can reduce those harms by maybe flossing every other day. Um, and there are also a whole bunch of social determinants of health, which will be discussed later on, that affect your ability to get healthcare services. So we don't exist in a vacuum, and providers have to keep that in mind. And there's also individualism. Every person presents with their own needs and strengths, as well as a spectrum of harm and receptivity. So what might work for one person might not work for another, even if they have the same condition. And so there requires a spectrum of intervention options, which is kind of what we talked about before about choices for people after they graduate high school. And then autonomy. Providers offer suggestions and educations, but at the end of the day, individuals make their own choices about treatment and health behaviors to the best of their abilities. And as providers, we can only support and guide. Then there's also incrementalism. Any positive change is a step toward improved health, and positive change can take years. We can also understand and plan for backward movements. So, for example, someone who tries to quit using drugs, they might go, instead of drinking every day, they'll drink 4 times a week. And then that's a positive change. And then even if they go the week after that for 5 times, we plan for that. And then from there, go forward. And then last but not all, accountability without termination. So at the end of the day, patients are responsible for their choices and they have the right to make harmful health decisions. Providers are there to help understand their consequences and that they're their own, but they don't get mad and won't stop seeing a patient because of that. So here are some examples of harm reduction for drugs. Probably the most well-known one is Narcan, which I'll talk about in a second. There's also information on safer drug use. So for example, something that's really important is set and setting, especially when you are taking a hallucinogen. So that means being in a setting that is very calming and also in a good mindset. And so providing this kind of information reduces the risk of overdose. There's also drug consumption rooms, and these are overdose prevention centers or supervised consumption sites, and they can reverse an overdose. There's also a program called, I'm actually forgetting what it's called, but basically you can call a number and you can take drugs with someone on the phone, and they'll just check on you every 10, 20 minutes, like, hey, are you awake? Are you doing good? And they won't get you in trouble, but if you stop responding, they have your location and they can send someone to check on you. There's also needle and syringe exchange programs. So clean needles reduce the chance of endocarditis. You can also spread HIV, hepatitis, other kinds of infectious diseases through using the same syringe or needle as a different person. So these exchange programs reduce the risk of that. And then also naloxone. This is overdose prevention and reversal. And naloxone is the generic name for Narcan, which is the brand name. Basically, how it works in your brain, you have a whole bunch of endogenous opioid receptors, and these things usually bind to endorphins in your body, and you have a lot on your brainstem specifically. Your brainstem controls your breathing, your heart rate, more of those autonomic nervous system parts. So what happens is opioids, which are inhibitors, they bind to these opioid receptors, and then they can cause you to stop breathing, and that's what leads to respiratory failure. However, naloxone is an antagonist, so it competes with the opioid to bind to the opioid receptor, and it displaces existing opioids on the receptors and prevents them from binding anew. So it pretty much prevents a person from having an overdose, which is very, very important. And the good thing about Narcan and nasal spray, Narcan and naloxone, it doesn't have any negative effects. So if you suspect someone is having an overdose, but you don't know and you have Narcan, do it anyways. They are not going to get hurt from that. Yes, Josephine?
Right. There was I don't know if we're going to get more details about this later, but on the progress check that we took before we began the program, one of the questions was the forms that we could have an intake for naloxone. Besides nasal sprays, are there any other forms that people could ingest safely to receive the effects of, negating drug use? Sorry, negating the drug effects?
Naloxone is the main one, and it specifically only works for opioids. I'm not sure, are you talking about like trying to quit drugs or just something that will competitively bind so that it doesn't affect you? Because naloxone and Narcan is like the main one.
The method of administration for Narcan. Not
Oh,
just like
yeah.
nasal, are the different ones? I don't know if
Yes. Yes, I think it also works intravenously, but that is a lot harder. Like for someone who's not a healthcare professional, they might not find it. And I don't think it's over the counter versus the nasal spray is over the counter. Yes, Jalen?
Can you explain what Narcan is?
Yeah. So, like I said, Narcan is the brand name of naloxone. Narcan and naloxone are the same thing, and it just displaces the opioids that are bound to the opioid receptors, and it prevents respiratory depression. And so because opioids are inhibitors and they cause you to stop breathing less, when it displaces these opioids, it um, prevents opioids from binding to them and can prevent respiratory depression. Does that make sense?
Does it only work for opioids or does it work for other drugs as well?
Just opioids.
Okay, thank you.
Yep. So yeah, if you can get trained, if you're in New York State, you can get Narcan for free and get trained for free, and it's good work. Also, I know that through Columbia University, you don't have to be a student. You can get trained on both Narcan administration and drug testing strips, so you can see if there's fentanyl. And fentanyl is extremely potent, and even a tiny amount can cause an overdose, especially for someone who's not expecting it. So I really recommend you check that program out. So, some more harm reduction examples. There's opioid agonist therapy. So these are things like methadone, buprenorphine, and these are opioids that are they're more long acting and they take longer to release. And so they change the way that the brain responds to pain, but it lessens the painful symptoms of opiate withdrawal while blocking their euphoric effects. So someone doesn't really have any I guess, reason or driver to take the opioid besides their own addiction. And so it's a good way to get people off opioids. There's also housing. People who have housing are less likely to overdose or to be have other sorts of harmful effects. Then there's the fentanyl test strips, like I said, and legal and paralegal services too. Jalen, do you have a question?
Yeah, my question is, so like if you carry around like the Narcan, like how do you know like if someone's having a reaction to like fentanyl and but you don't know if it's like fentanyl or like opioid, how do you know the difference like in reaction
Well,
between the two?
fentanyl is a type of opioid. So opioids like
Okay.
a wide class, and that can include things like fentanyl, but it can also include heroin, morphine. There are a whole it there's both synthetic and non-synthetic. And so I would say something that's a good idea is a sternum rub. So if you get your three knuckles and you rub it right over here. Oh, my camera's moving. It hurts. It hurts a lot. So if you do that to a person who is sleeping, they'll wake up. But if a person is overdosing, they won't. So that's a good way to check to see if they're responsive or not. And so I'll try to get to your questions later, but why do you think harm reduction is necessary? Well, for one, there were more than 100,000 drug-involved overdose deaths in just 2023, and only 1 in 10 people with a substance use disorder have received treatment. And nearly all people who use a with a substance use disorder who didn't get treatment at a specialty facility didn't think they needed treatment. So we want to reduce the harms for those people as well. And more than 1/10 of all people diagnosed with HIV in the US in 2018 reported injected drug use. So, if we are doing needle and syringe exchanges, for example, this can reduce the amount of people that get an HIV diagnosis. And so harm reduction is not just about safer access to drugs, it's also about increasing access to healthcare, social services, and treatment. These are all very connected. A comprehensive prevention strategy and continuum of care decreases overdose fatalities and acute life-threatening conditions. And by reducing stigma associated with people who use drugs and promoting a philosophy of hope and healing instead of abstinence and blame, harm reduction builds community and can increase protective factors for people who use drugs and their families. So, if you want to type in the chat real quick, we don't have time, but what do you think? You can answer any of these questions. What would harm reduction in the US look like in practice? What is the role of police officers in protecting people who use drugs? How has the idea of harm reduction in the public eye changed within our lifetime? And what resources do you know of for harm reduction? Any kinds, but specifically for people who use drugs. So feel free to type in the chat. More awareness that explains the effects. Yeah, exactly. So replacing something like dare with some kind of educating program. Anything else? Learning more about the effects of drugs not only among children in schools but also among adults. Yeah, because that way adults can teach their community. More awareness, housing, yes. And police can carry Narcan, yes. And actually use the Narcan instead of having some other harm be a gateway. Poison and drug support hotlines. Yes, these are all really great ideas. And so I wanted to talk a little bit about Portugal. So in the late 1990s, Portugal faced an explosion of heroin use with roughly 350 overdose deaths a year and a wave of HIV/AIDS. So what did Portugal do? Well, instead of banning heroin or opioids, they moved away from the US drug war model, which prioritizes seizures, arrests, and prison sentences, and instead focused public dollars on healthcare, drug treatment, job training, and housing. And it also decriminalized all drugs. So if a police officer sees a person who is on some sort of drug, instead of arresting them, what they'll do is they'll give them a referral directly to a healthcare center and they'll follow up with them, but they won't punish them. And this allows people who use drugs to feel a lot more comfortable reaching out for help. And because it's taxpayer funded, it was free and easy to navigate. And so this is Miguel Moniz, an anthropologist at the University of Lisbon. He's describing Portugal's official view of addiction. He says someone who has a problematic drug use isn't someone who is a criminal or a moral or someone who has a moral failing. They're someone who has a health problem, a physical or mental health problem. And that's something that I think the US could really learn from because people who use drugs aren't criminal or they aren't immoral. They just don't have resources to help them get away from that. And so, after decriminalizing personal drug use, they reinvented the role of police. And so, when cops see people using personal amounts of drugs, They schedule meetings with teams of counselors. These aren't mandatory, but they encourage people to attend. And roughly 90% of people referred to counseling sessions do turn up for at least one session. So, people in Portugal are 45 times less likely to die from an overdose compared to people in the US. And they rarely serve jail or prison time, allowing them to focus on other things, and they don't live with criminal records, so they can easily secure a job and housing. So yeah, here's a conclusion. Portugal's model really re cut drug tests by 80% and reduced HIV and hepatitis deaths in half, whereas in that same period in the US, drug deaths exploded by more than 500%. So really quickly, some things you can do. Teach being a health liaison. You're already doing great. Treat people who use drugs with respect and compassion and don't contribute to already great stigma. Advocate for treatment over incarceration. It greatly increases harm. Carry naloxone with you. Take the Columbia course that will teach you how to administer it. It's free. Write down and keep track of resources you can share with people in need. Educate yourself on ways to reduce harm, not just with drugs, but overall. And then recognize creative ways to reduce harm in your community. And really quickly, Good Samaritan law, if you see someone who is having an overdose or they are very drunk, even if you're under the age of 21, in New York State has a Good Samaritan law, but all 50 states and Washington, D.C. have a version of it. You can call the police and you are protected from sharing drugs, possessing marijuana and drug paraphernalia, alcohol, and controlled substance up to 8 ounces. You won't get in trouble. You will just be protected for helping someone. However, this doesn't count for selling. And yeah, really quickly, if you want to take a screenshot of this, this is in New York, harm reduction centers receiving naloxone, never use a loan hotline. That's what I was talking about earlier. And then the suicide crisis and support lifeline. And yeah, thank you very much. And if you have any questions, feel free to reach out to me at va2519@columbia.edu. And I also have office hours this Tuesday at 6 p.m. EST. Thank you.
Thank you so much, Valentina, for teaching us all about harm reduction and elucidating strategies for mitigating negative health outcomes. And now Mickey will be teaching us about depression.
All right, hi everyone. My name's Mickey, and I'm going to go ahead and share my screen for my depression slides. Can everyone see it?
We can't see it yet. Maybe try again.
Okay, sorry, I just got randomly kicked out of the Zoom meeting. But let me share. Can we all see it?
Yes.
Okay, perfect. Okay, so today we'll be talking about depression, and my name's Mickey, and we'll get started. I don't have any disclosures, and I've partnered with the VPNS Statement of Partnership and Humility to increase equity. And for today's topic, we'll first start off by familiarizing ourselves with what clinical psychology encompasses and the ways that clinicians use different tools to diagnose different mental health conditions and also understand psychological theories and frameworks that are used to inform how we learn and practice psychiatry and we'll also discuss the different diagnostic criterion for major depressive disorders and other types of depressive disorders. And we'll analyze the different molecular mechanisms of mood disorders like the different neurotransmitters and how medication therapies can intervene to alleviate these symptoms. And we'll consider psychosocial treatments to manage depression with or without medication therapies. And then finally, brainstorm how us as healthy liaisons can help our community tackle the mental health stigma and the accessibility and equity issues surrounding mental health care. First off, we'll start with a clinical case, and then we'll dive more into the different subsets of psychology and depression. All right, so we'll start with a myth or fact activity. Does anyone want to volunteer and read these facts and myths or myths? Um, Not sure if I can. So I think my Zoom is crashing. Um,
No worries.
but
There are a few hands raised, so I can
yeah,
call on somebody for you. Sadie.
you can go ahead and call on someone.
Okay, myth or fact? Depression is just sadness and will naturally go away on its own. Depression manifests in physical symptoms like fatigue, pain, appetite changes, and depression and grief are the same thing.
Mm. Does anyone volunteer to decide whether or not number one is a myth or fact?
Medina.
I think number one is a myth because depression isn't just sadness, it's like a huge aspect. And even if things are going well in life, usually people get depressed because it's like based on their own, like, it's based on many factors, not just like emotions.
Yeah, perfect, exactly. Throughout this lecture, we'll learn that depression is a very, very complicated, multifaceted condition. Um, Perfect. So that is going to be a myth, and anyone want to go for two?
I saw Munisa first.
I think it's definitely a fact because I know like cortisol is like stress and it could definitely like lead to bloating and things like depression. It's not like it's maybe not direct, but it's definitely like a manifesting factor.
Mm-hmm. Perfect, you are correct. Number two is going to be a fact.
I think Mickey might have lost connectivity. We're having some storms here in New York. We'll give it a minute and hopefully she can rejoin.
Hi, I am so sorry. But I am back, and hopefully this is gonna be much better. But let me go back really quickly.
No worries at all. You left off on the third part of the myth or fact exercise.
Okay, perfect. Has anyone volunteered to read this out yet? If not, whoever has your hand up can go ahead and read that out for me, please. Jalen can go ahead. Thank you.
Do I read the first one?
The third one, please.
Okay. Depression and grief are the same thing.
Perfect. Do we think that 3 is going to be a myth or fact? I see Kumba's hand.
I said that 3 is a myth because grief is a natural response to loss, while depression is like a mental health condition that is more long lasting and like it's more severe than grief.
Perfect. You actually got it like that's a perfect textbook definition of the difference between depression and grief. So you got that spot on. Grief is what we're going to consider a natural response to loss. And perfect. Thank you guys for volunteering. And we'll go ahead and talk about our clinical case. It's a bit lengthy, but does anyone want to volunteer to read this one? Josephine?
Right. Clinical case. Bruno is a 15-year-old male in 10th grade who presents to an outpatient pediatric clinic complaining of persistent low mood, fatigue, and difficulty concentrating during class for the past 2 months. He doesn't enjoy soccer anymore and instead spends most of his day in his room on his phone. Mom reports that Bruno is increasingly withdrawn, irritable, and argumentative at home. He admits feeling hopeless and often thinks, "I wish I could just disappear," or "I wish I could sleep forever." He also reports poor sleep, waking up in the middle of the night and unable to fall back asleep. Medical history includes mild asthma, and Mom has a history of major depressive disorder, or MDD, if I interpreted that right.
Yes. Um, so usually we won't use bold cards as a way to assess and evaluate clinical cases like this because it doesn't work very well with psychiatric conditions. As we can see, the acronyms of bold cards usually works with like physically presenting conditions and complaints. Because of this, we have much better acronyms specifically for psychiatric conditions like stage caps and DIGFAST, which we're going to use later on. And for the sake of time, we're going to just keep this clinical case in our heads as we go through these slides, and then we'll come back to this later on. So, what is clinical psychology? Clinical psychology encompasses many different domains of mental health conditions, concerns, and criteria for diagnosing and treating these conditions. And we rely on the science of psychology to treat these complex human problems. And this means that we're going to use um, evidence-based facts and understandings and to research the etiology, which means causes of mental health conditions. And then from this, we can strategize how we can best target interventions to alleviate these conditions. And according to this National Institute of Mental Health taxonomy of mental health disorders, we can separate them into things like internalizing versus externalizing conditions. And then we have a bunch of different ways to categorize different conditions on the spectrum. And we also have the diathesis stress model, which is a pretty basic model that we use when we first learn psychology. The diathesis means predisposition, and stress refers to traumatic events, major life changes, chronic stress, and social isolation. So in theory, this model is what we use to identify the risk factors and possible causes of someone's experience with mental health conditions and what makes someone more vulnerable and at a higher risk for developing these conditions if they face in the face of stress. So diathesis or this predisposition refers to things like genetic factors, family history of mental illness, brain structure differences, personality traits, and chronic illnesses. Um, for example, major depressive disorder has a heritability rate of 40% compared to 60 to 85% for bipolar disorder, which means that when we treat bipolar disorder, we want to more heavily consider the impact of heritability. So we want to ask more carefully about family history of bipolar compared to a patient who's coming in for a major depressive disorder. And we usually say that if given the same level of stress, someone who has a higher diathesis or a vulnerable like pre-existing vulnerability will have a higher risk factor of developing a psychiatric condition or most of the times depression in response to the same level of stress. And we also use a biopsychosocial model to explain and to contextualize and kind of understand someone's experience with mental health conditions. And this is pretty self-explanatory, I believe, because I think it represents a lot of intersections that we have to think about within community health and within medicine, that there are multiple determinants of someone's mental health, including biological, social, and environmental, and psychological circumstances within their lives. And we have the DSM-5, which is going to be the Diagnostic and Statistical Manual of Mental Health Disorders, the fifth edition. And we like to use and the clinicians use this one standardized manual to diagnose mental health conditions because it's a very good a very good way to standardize these criterion and make sure that everyone's on the same page. And for example, we have providers, clinicians, patients, and insurance companies on the same page when we're diagnosing. So when we diagnose, the most important things that we look for are the core features of the disorder. We're going to talk about this later on, and also consider other symptoms that for core features, these symptoms must appear within a patient's experience in order to qualify for a diagnosis, while other symptoms, they can they're optional too when we're diagnosing. And then we also have to evaluate whether the symptoms are sufficiently severe to cause a marked impairment in social or occupational functioning, or if it necessitates hospitalization. So this is very important because we have to evaluate the impact, the level of impact of someone's symptoms in their social and occupational lives. And we also consider the time frame for persisting symptoms, age of onset, and age of onset can be more important in things like ADHD and childhood disorders, but we might not need this for depression. And we have to make sure that these symptoms are not better explained by another mental disorder, and not attributed to physiological effects of a substance such as drug use, medication, or the side effects of other treatments or medical conditions. All right, for diagnosing major depressive disorders, we want to identify the presence of 5 or more symptoms within a same 2-week period. And we need to have at least one core symptom. And one of these core symptoms can either be depressed mood or anhedonia, which is a loss of interest or pleasure in doing things that usually brings you joy. And other symptoms can be significant weight loss or weight gain, insomnia or hypersomnia, psychomotor agitation or restlessness or slowing down, fatigue or loss of energy, feelings of worthlessness, shame, guilt, decreased concentration, and recurrent thoughts of death or suicide. So you would want to have at least one core symptom and then 4 or more other symptoms under other symptoms. And we use SIGCAPS. SIGCAPS is a very useful clinical adjunct in addition to using the DSM-5 to help primary care providers distinguish symptoms for mood disorders. So SIGCAPS will represent sleep, interest, guilt, energy, concentration, appetite, psychomotor, and suicide. This is a great acronym for like outlining the most important diagnostic criteria for MDD, because these, as we see, these are basically like a summary of everything that the DSM-5 outlines for us when we need to diagnose MDD. And when a patient qualifies for 4 or more SIGCAP symptoms plus depressed mood or anhedonia, reminder that this is the core symptoms outlined by DSM-5. It suggests a possible diagnosis of depression, and then this means that we need to further assess, and this will bring us to our next steps for a clinician. So we also use Fold's hierarchy. Fold's hierarchy looks like a pyramid, and it's essentially a very useful clinical reasoning tool for providers to differentiate the cause and reversibility of psychiatric symptoms in cases of MDD. And oftentimes, MDD is comorbid with other mental health conditions, and it can also be comorbid with chronic illnesses, cancer, and neurological disorders. So the Fold's hierarchy is useful to determining whether or not these symptoms that we suspect are due to MDD are actually due to MDD or due to a natural progression of diseases like cancer and chronic illnesses, or a reaction. So this might be like grief or adjustment to like major life-changing events, or if these symptoms are more aligned with personality related coping patterns or a true comorbid psychiatric illness. So essentially, Fold's hierarchy is important when we want to figure out, are these symptoms truly representative of a purely MDD diagnosis, or if it's manifesting as a comorbid condition with something else that the patient already struggles with, and whether or not like we can use other things like personality, um, um, chronic illnesses, and um, like a natural reaction towards stress as a way to better explain these symptoms that look like MDD. And the most reversible things on the Frode's hierarchy are going to be neurotic symptoms and vitamin deficiencies, because these are things that we can very easily treat and identify. And then the least reversible are going to be personality disorders, which are much more ingrained. We also have other types of depressive disorders. So when we talk about differential diagnoses, we have multiple different diagnoses that can be possible when considering a bunch of symptoms. So in addition to suspecting MDD, we also want to rule out other types of depressive disorders. So we have things like PDD, PMDD, and DMDD. PDD refers to persistent depressive disorders, and this is previously known as dysthymia. This is a chronic form of depression, and within children, we need 1 year of persisting depressive symptoms and 2 years for adults. And we usually say that PDD might be even more like debilitating than MDD because it lasts for such a long period of time. But usually the symptoms might be less severe, but then lasts a much longer time. We also have PMDD, which is premenstrual dysphoric disorder. This is a much more severe form of PMS or premenstrual syndrome with impairing mood symptoms that occur during the week or two before the onset of menses during the luteal phase. And this PMDD is going to be cyclical and hormone related. DMDD is disruptive mood dysregulation disorder. We see this as a childhood disorder that is manifest by severe recurrent temper outbursts and persistent irritable mood that is not age appropriate. So a child between ages of 6 or 18 who are presenting with these recurrent temper outbursts that are not appropriate for their age level might be um, might be might need to come in for an evaluation for DMDD. And we also have bipolar and cyclothymic disorder that also presents with very similar um, symptoms to the MDD, because bipolar depression are very frequently misdiagnosed as unipolar depression. Bipolar depression involves a depressive phase and a manic phase. In bipolar 1, we need to have at least one manic episode in order to be diagnosed with bipolar 1, with or without depressive episodes. So mania refers to abnormally elevated or irritable mood, high energy, and risky behavior for at least a week. So usually when you come in for concerns about MDD symptoms, clinicians will also want to ask whether or not you're experiencing symptoms of mania in order to differentiate whether or not you're having symptoms of mania in addition to depression, or if it's just depression by itself, unipolar depression. Bipolar 2 will require at least one hypomanic episode plus one MDD episode. So hypomanic will be like a less severe version of mania. You are not reaching the full threshold of mania, but you're still presenting with abnormally elevated mood, plus an MDD episode, so like severely depressed mood. And it's very critical to screen for manic or hypomanic symptoms before diagnosing unipolar depression to rule out bipolar. And then kind of on the same spectrum, cyclothymic disorder is a chronic mood instability that lasts for 2 years in adults and 1 year in children. Cyclothymic disorder refers to alternating periods of mild depressive symptoms and hypomanic symptoms. So, in essence, this is like not reaching full MDD diagnosis and not reaching full bipolar 1 or bipolar 2 diagnosis, and this is often what we consider precursor to bipolar. So people with cyclothymic disorder should be monitored very closely and managed with psychosocial treatments or medication to prevent the onset of bipolar. And dig fast is also another acronym like we like to use when talking about bipolar disorders. We also have other conditions that mimic symptoms of depression. So the most common ones are thyroid dysfunctions. So hypothyroidism always manifests with very similar depression-like symptoms like low energy, weight gain, poor concentration, depressed mood, fatigue. So we want to check THS and free T4 levels in individuals with new onset depression to rule out thyroid dysfunctions. And this can be easily treated with thyroid medication, and this often resolves mood symptoms. We also talk about vitamin B12 deficiencies, which is very essential for neurological and cognitive function. So someone who's having a deficiency of vitamin B12 will present with cases of like cognitive changes and atypical depression. So that's also very important. And then we also have non-pathological bereavement, meaning that if someone is experiencing grief, it's a normal reaction to a significant loss. So that's not what we consider pathological. But then we can also closely monitor this person's process and experience throughout this grief process to ensure that they're receiving adequate mental health resources and support to prevent progression into mental health conditions. All right. We also have PHQ-9, which is a patient health questionnaire for a very quick screening of depression and for people who are already diagnosed with depression to see how their depression has changed over time following treatment plans. This is very quick, only 9 questions, and pediatricians and primary care physicians like to give this out during annual exams, physicals to screen everyone for depression. And yes. And we also, this is a very interesting a research study published about the cost effectiveness of universal routine depression screening for adolescents in primary care. And this refers to clinical tools like PHQ-9 in order to screen everyone for depression at a routine level during annual exams to make sure that adolescents are receiving the necessary treatment and management if they are presenting with any signs of early development for depression. And we also have neurotransmitters. And these things are going to be important in deciding how we're going to manage depression with medications. And the most important neurotransmitters are going to be serotonin and dopamine when we talk about depression. And the antidepressant classes go into SSRIs, SNRIs, atypical antidepressants, tricyclic antidepressants, monoamine oxidase inhibitors, and a combination of these. And you're not required to know all of these antidepressant classes or even the medications that go under these categories or the mechanisms of actions. But it's important that the key takeaway from this section of the lecture is that when clinicians and patients work together to figure out what the best medication therapy is, it often takes a very long time to figure out what is best for this particular patient because everyone's different when responding to different medications, and there's a lot of trying out, experimenting, exploring different classes, different types of medications, and different doses to figure out which one will be the best, and then close monitoring to figure out if that's the best way to continue or if adjustments are needed. Yeah. And we also have psychosocial treatments, which involves cognitive behavior therapy, which is CBT, and what we conventionally refer to when we talk about therapy or talk therapy. We also have interpersonal therapy, including family therapy and couples therapy or marriage therapies, and dialectical behavior therapy, which in contrast to CBT involves more of teaching patients how to actually use tools and different skill sets to manage and develop resilience. And when patients do have treatment-resistant depression, or if they have tried many different medications, many different types of other psychosocial treatments and aren't really coming to a place where they feel comfortable, they might try TMS or ECT. And if you're interested in learning more about these two, there are links at the bottom where you can read about these. And very important is that physical activity, regular exercise is so important in improving depression and anxiety in children and adolescents. And this is a systematic review talking about this. I'm finding that exercise is extremely crucial in managing depression and anxiety symptoms, which is something that I think will benefit all of us. And so, in terms of statistics of depression, we know that depression is extremely prevalent. It is estimated that 280 million people globally are living with depression in 2019, and this number definitely has increased considering our last few years that we've the different things that the world has struggled with. And according to CDC, about 13.1% of U.S. adolescents and adults 12 or older experience depression. So that's about 1 in 8 of us. So because of these statistics, what's very important for us as a community and especially as healthcare liaisons to work on is to destigmatize mental health. So what can we do as health liaisons? Like Valentina said during the harm reduction lecture, using person-centered language is very important. So this will help center the patient and humanize the patient, the individual, rather than categorizing them using their mental health condition. So instead of saying like the depressed person, you're saying that the person with depression is dealing with something, something. And it's also important to promote open discourse and share lived experiences and testimonials of mental health journeys, whether or not these journeys end up being a really positive change, or it can be really real and honest sharing that mental health journeys are really difficult and then last like a lifetime of learning how to cope and manage with your struggles, and also peer support programs and community workshops, talks, and campaigns to learn more about these different diagnoses and to spread awareness and to, most importantly, humanize these conditions by learning from real life people who have who are willing to share these lived experiences. And so finally, I just want to like bring it to a closing moment by acknowledging that there's so many people around us, especially within our communities and within even like the larger like pop culture industry where everyone struggles with mental health. And it's so important to, um, be cognizant that this is like a shared experience and there is no shame, there's no guilt, and reaching out for support, and that depression isn't something that's going to be like a hindering thing, and that a lot of people who struggle with depression go on to be able to like learn how to manage and cope with their conditions, and they're very resilient, and then go on to be very successful in their lives. Yeah. So thank you so much for listening, and if you have any questions or comments, we can totally discuss this more in my office hours.
Thank you so much, Mickey, for teaching us about depression and the signs, symptoms, screening tools, medications, and treatment plans that come along with it. And now I get to introduce Oni, who will be teaching us about memory health.
Hi everyone, let me just share my screen. Thank you so much, Mickey, for that amazing presentation. So today I'll be presenting on memory health. So disclosures, I have none, and in the service of increasing equity at VPNS, I consider the VPNS guidelines for promoting an anti-bias and inclusive curriculum. Okay. So learning objectives. So by the end of this presentation, you should be able to define memory health, understand how memory works, identify common reasons memory fails, recognize the difference between normal memory slips and serious memory problems, and also apply strategies to improve memory and support long-term brain health. Okay, this is the outline of the presentation. And do we have any volunteers who wants to read this clinical case? Okay, so Josephine was the first person, so go ahead and unmute yourself.
Right, thank you. The clinical case here, Maya is a 16-year-old high school student who has always done well in school. Over the past 2 to 3 months, she has started to notice changes in her memory and focus. She often forgets instructions immediately after hearing them, loses track of what her teachers are saying during class, and finds herself rereading the same paragraph multiple times without retaining the information. As a result, her grades have begun to slip, especially in math and science. Feeling frustrated and confused, Maya explains, I feel like my brain just can't hold things anymore.
Thank you so much, Josephine, for reading that. And so throughout the presentation, think about this clinical case because we'll revisit it at the end. Okay, so what is memory health? Memory health is how well your brain can learn new information, store memories over time, retrieve memories when you need them, and adapt to stress, learning demands, and aging as well. So how would you guys rate your memory today? You can put a number in the chat, 1 being I forgot why I opened my phone, and 5 being elephant memory. Okay, so we have a common trend of 3 and 4. I would say 3 for me as well, just because I had some memory slips today. So, okay, next slide. So ever see or hear something and it's gone a second later? This is your sensory memory, the very first stage of memory that briefly holds raw information from your senses before your brain decides what to keep. Sensory memory lasts milliseconds to a few seconds. Visual information, which is iconic memory, fades in about half a second. And auditory information, which is echoic memory, lasts about 3 to 4 seconds. And have you ever walked into a room and forgot why you went in? I think this happens quite often for me, because this is actually called a classic glitch in your working memory, which is the system that holds onto temporary information while you're using it to complete a task. So working memory is extremely limited in both capacity and duration. Most humans can only hold about 7 items, like digits or words at once. That's why a phone number is 7 digits. If you get distracted by a notification or thought on your way to a room, that new information can bump your original goal out of your mental workspace. Have you also ever remembered something from years ago but forgot why you studied something yesterday or what it was? Well, this is your long-term memory, the system that stores information from days, years, or even a lifetime. It holds facts, experiences, skills, and habits once they have properly encoded. Information only reaches long-term memory if it is processed deeply, and ways to do that is through sleep, repetition, meaning, emotion, connections to what you already know to strengthen those memories. If information is rushed, crammed, or never reviewed, it may never fully consolidate and can be difficult to retrieve later. So all of this is called the information processing model, which starts with sensory memory, then with attention goes to short-term working memory, and then transferred to long-term memory, and then it can be retrieved again with short-term memory. And short-term memory is, it's important to practice it and to continue to review things you learn to get that working memory going. Okay, so share a funny thing you've forgotten recently. I'll go first. You can also put it in the chat. For me, I was walking and this alumni from my school I met like 4 years ago said hi to me, and I completely forgot their name, and I felt so bad just because I love to say hey in the person's name, but I forgot it because I haven't seen them in such a long time. So you guys can just share your responses in the chat. Oh, you forgot all the topics I studied for the term. That's real. I also had something like that happen to me freshman year. That makes 2 of us, yeah. Okay, so next, before you start worrying about, aging and memory loss and all of that stuff, memory slips are normal. Our brains are constantly managing a cognitive load, the total effort being used in our working memory. So when we are stressed, tired, or distracted by mobile phones, our mental RAM becomes even more crowded, making these slips more likely to happen. So there's nothing wrong with you. It's just, it's normal to happen. It's part of being human to have memory slips. Okay, so what neurodegenerative diseases, dementias, relate to memory and impacts it? So first we have Alzheimer's disease, which can begin years before symptoms appear, gradually affecting memory. Vascular dementia is caused by strokes or reduced blood flow, leading to a stepwise decline in memory and thinking. And Lewy body and frontotemporal dementias affect attention, behavior, and language, which support memory. You also have cerebrovascular and neurological disorders that also affect memory. So, stroke and TBI, which is traumatic brain injury, can damage memory suddenly or over time. Repeated head injury weakens memory circuits. Multiple sclerosis, HIV, tumors, and epilepsy disrupt neural communication. Okay, so now we're going to do a little true or false activity to see how well your memory is from other presentations. Okay, this could be a presentation you just heard or something presented, for example, last week. Okay, so number one, you can put this in the chat, by the way. Memory, or you can also raise your hand. It's up to you. But memory loss is always the first symptom of dementia. True or false? What do you guys think? Okay. So I'm seeing a lot of false. Does anyone want to explain why that is, why they think that's the answer? You can put it in the chat or you can speak out loud. Okay, Josephine, you can unmute yourself.
I might be cheating because I have my notes right in front of me from last week. But dementia is not only categorized as memory loss, but also cognitive function. So while memory loss might be one of the core symptoms that we first see, it could also be muscle trembling or a inability to perform more coordinated tasks, such as like writing complex letters, or aphasia, such as forgetting what you're about to say, and being able to process languages, which technically involves memory, but it also involves other parts of the brain.
That was amazing. Good job. That's exactly it. So this is false because, like what you said, in frontal temporal dementia, things like personality, language, and those behavioral changes that you mentioned often occur way before memory loss. So good job. Okay, so next. Delirium is an acute decline in cognitive functioning that is commonly seen in elderly patients who have had long stays in hospitals or long-term care facilities. Is this true or false? Okay. I'm seeing a lot of truths. Okay. Okay. Let's see. This is true. Good job, guys. And this is actually from Emma's presentation from last week. Okay, next. In neuropalliative care, pain is only physical. True or false? Okay, you guys are so fast with it. Wow. Like you have like your answers ready. Okay. Let's see like the last response that we get. Okay. The answer is false. So neuropalliative care recognizes total pain, which includes physical, emotional, social, spiritual, and practical pain. So this was just presented by Sarah during the first presentation. Okay, next. Dementia is a normal part of the aging process. True or false? You guys are so good at this. Okay, yeah, it's false. While age is the biggest non-modifiable risk factor, dementia is not a normal part of getting older. Okay, last one. Early onset dementia can occur in people as young as their 40s. True or false? Okay, you guys are amazing. Yeah, it's true. It can occur in people in their 40s or 50s, so good job, guys. Okay, next slide. Okay, so some statistics. 55 million people are living with dementia worldwide. An estimated 7.2 million Americans are living with Alzheimer's dementia, and 1 in 9 people aged 65 or older has Alzheimer's disease. Okay, now we're gonna do another challenge. So this is called the Test Your Working Memory Challenge. So you'll be given 10 random emojis on the next slide, and for 15 seconds, you're going to try your best to remember these emojis. And it doesn't have to be in order, but you have to think about it. You're not allowed to write it down. Try to remember it as best as possible, because after 15 seconds, you're going to put it in the chat. So I am going to set a timer up right now for 15 seconds. Okay, is everyone ready? Just say ready if you're ready in the chat. Lock in. Okay, ready? Ready? Okay. In 3, 2, 1, go. Two seconds left. 1, 2. Okay, that's it. Right in the chat. Put down what the emojis were in the chat right now. You have another 15 seconds to do this. Okay. I'm seeing a lot of apples. Okay, 3 more seconds. 3, 2, 1. Okay. Wow, you guys are amazing. I'm seeing a lot of similar emojis. Okay, these were the correct emojis. Okay, so how many did you remember? You can put your answers in the chat. Did you remember 5, 2, 1? I know some of the beginning ones said apples. Wow, you guys are so good. Okay, so like I'm seeing like 7, 4, 5, so like a couple. 90%, okay. 7, yeah. So I see Josephina's getting ahead. Okay, you're right. Yeah. So you likely recalled 5 to 7 items because our short-term memory capacity is about 7 items. So it's hard to remember all 10 at once, but there are ways to help. So often we remember the first and last items best, which is called primacy and recency. So you tended to recall the apple because that is the very first emoji given to you. And ways to actually do better at this is to really group those similar emojis. So things like apple and basketball are round items, right? And then piano and guitar are music things. So this is called chunking information. So now, the night shift. This is the glymphatic system. So the glymphatic system is the active neural cleaning system that happens at nighttime. So this information is going to be presented to you in some myth or facts. I want to see what you guys know about the system. Okay, number 1, sleep is just rest. Your brain shuts down at night. Myth or fact? Okay, so I'm getting some false myths. Yeah, this could also be a true or false question. Okay, so you guys are right because it is a myth and it is false. So during sleep, your brain activates the glymphatic system, which clears waste products linked to memory loss. Okay, next. The brain removes harmful proteins like amyloid beta while you sleep. True, false, myth, fact, what do you think? Okay. Okay. You guys are really smart people. It is fact. So the glymphatic system uses fluid channels and water proteins called AQP4 to wash out metabolic trash. Okay, next. Missing only one night of sleep doesn't affect brain health. Is this a myth or a fact? Okay, good job, guys. This is a myth. Even one night of sleep deprivation can raise amyloid beta levels by 25 to 30%, increasing stress on memory system. So it's so important to, get your sleep. You do not want to be sleep deprived. Okay, next. So now we have the sleep architecture and memory. So sleep, there's a 2-process model of sleep divided with homeostatic sleep pressure, which is basically the longer you stay up, the more adenosine increases and you get tired, right? And so when you go to sleep, this pressure is reduced. And so Then you have the circadian rhythm, which you know most likely heard already many times, which is your internal 24-hour clock. And this basically just tells your body to, you know, sleep or wake up. And it's controlled by daily routines and light exposure. And sleep is also divided in two stages called non-REM sleep, which is basically what's responsible for consolidating those declarative memories like facts or events, but also REM sleep, which is responsible for episodic memory. So really your emotional and procedural memory. Next. Okay, so ways to prevent memory decline. So you know how we talked about lymphatic system? Basically, because lymphatic dysfunction often precedes the clinical symptoms of dementia by years, supporting the system is a vital part of memory preservation. So strategies to enhance lymphatic function includes managing vascular health, which is controlling blood pressure and cholesterol, as hypertension reduces the arterial pulsations needed to drive lymphatic flow. Sleep hygiene is also really important, so really maintaining that consistent 7 to 9 hour sleep schedules, which ensures the brain has enough time in the N3 stage to complete its cleaning cycle. N3 stage is one of the stages of the non-REM sleep stage. And emerging interventions as well. So research into acoustic stimulation, which is using sound to enhance slow wave sleep, is being explored as a method to potentially boost lymphatic clearance and improve memory consolidation in the future. Okay, and another thing that can really help you to fuel that neuroprotection is the mind diet. So this is basically where you have green leafy vegetables, berries, nuts, whole grains, fish, and poultry, and no red meat and sugar. This diet has been shown to reduce the risk of Alzheimer's by more than half, which is crazy. Like 53%? Are we joking? Like, oh my gosh, that's amazing. So you can like tell your family and your health liaisons about this diet. It's a really important preventative measure you can do. Vascular health is brain health. So things like physical activity, 3 times or more a week is really important also for your memory, and it can reduce the risk of Alzheimer's by 30 to 50% as well, which is a lot. And so also building a reserve. So I feel like people don't talk about this a lot, but things like social engagement, you know, like talking to your friends can help you reduce your stress and also like help with depression as well. Neuroplasticity is the brain remodels itself across the lifespan, right? And mental friction, so actively learning language. So in school, pay attention to languages. Like try to learn a language, an instrument, instead of just passive consumption, being in class and not really listening, being on your phone, going on Snapchat. Like instead of doing that, try to be active, raise your hand, participate, and learn a language, because those things are really important. Jalen, yes, you have a question.
Yeah, so you were saying how like it's important to like when you speak to your friends, like it helps. But I feel like does it apply like does it like specifically have to be your friends? Because I feel like just telling like let's say you meet like a random stranger like on the train or something, just telling them like a story about it, like something that you're going through. I feel like that also helps as well.
That's a good observation. Exactly. It doesn't have to be your friends. Friends are an example, but it can be anyone. Because, you know, it's so easy to isolate yourself and just be in your room, especially during COVID time, just be in your room, going on Netflix, going on TikTok, scrolling, getting those dopamine, you know, buzzes, and to isolate yourself and not talk to anyone. In those moments, you're not using your brain, right? And so, like what you said, going out, talking to someone, having a conversation with a stranger is you using your brain, and it's going to help you really to, you know, really to protect your memory in the future and presently, right? And so the more you use it, the more you're protecting your memory, the more you have to, you know, process information, process sensory information, working memory. You're using your long-term memory to recall stories maybe from like when you were younger. That is you using your memory, and so that is going to help you and be a guard for you against memory loss. So good observation. Okay, next. So modifiable risk factors across the lifespan. So in your early life, education is so important. If you are getting lower education, like maybe you don't go to school, for example, that is really associated with reduced cognitive reserve. So it's important to get education. Things like hearing loss, hypertension, obesity, diabetes can affect memory as well, um, and just also increase the risk of dementia for patients. And late life, things like smoking, depression, physical inactivity, social isolation, visual loss, air pollution, can potentially also cause a cognitive decline in a person. And so up to 50% of dementia cases are potentially preventable. Okay, so if we put all of this together, right? So the integrated protocol for resilience. So sleep, get your sleep. Educate people on sleep. Getting that 7 to 9 hours of sleep is so important for that lymphatic clearance. Strain, so vigorous exercise and cognitive challenge, it's how we saw that getting exercise at least 3 times a week can really reduce the risk of Alzheimer's by 30 to 50%. So that is important for memory. The fuel is the mind diet, those plants and healthy food is really important. It reduced Alzheimer's by 53%. Connect with anyone, your friends, strangers, your teachers. Getting those social interactions are also important. And make sure you're, monitoring your blood pressure, your glucose levels, because those are vascular risk. So now we are back to the clinical case. Does anyone want to read it, or do you guys remember it? Okay, Juliet, please unmute yourself and read this presentation. Yes, let me ask to unmute. Okay, Juliet, do you want to read this clinical case?
Yeah, sorry, my mic was being weird.
No, it's okay.
Maya is a 16-year-old high school student who has always done well in school. Over the past 2 to 3 months, she has started to notice changes in her memory and focus. She often forgets instructions immediately after hearing them, loses track of what her teachers are saying during class, and finds herself rereading the same paragraph multiple times without retaining the information. As a result, her grades have been split, especially in math and science. Feeling frustrated and confused, Maya explains, "I feel like my brain just can't hold things anymore."
Maya is so real. I feel like that happens to so many people. I think we've all been there before. So let's analyze this. What type of memory is most likely being affected in Maya's case? What do you guys think? So think back to the information processing model that we talked about in the beginning. Okay, there are chat. What is another name for short-term memory? Let's see. Good job. Yes. Okay. Working memory, working short-term memory. What factors might be contributing to her mental memory struggles? Okay, lack of sleep, diet. Okay, you guys are doing so well. Stress. Okay. Yes. What can Maya do to help improve her memory? Sleep, exercise. Good job. You guys are awesome. Exactly. So working memory with downstream effects on long-term memory is being affected. Factors contributing to her memory struggles are poor sleep, divided attention, cramming, and stress. And she can get more sleep, study in space sessions, reduce distractions, and use active study strategies. So chunking, for example. Okay, now we are going to watch this really cool video. I love it. And it's going to give you instructions during it, but everyone should participate and listen to the instructions. Okay, let me know if you can see it. Can you see it?
This is a test of selective attention.
Okay.
Count how many times the players wearing white pass the basketball. How many passes did you count?
You can put it in the chat.
The correct answer is 15 passes. But did you see the gorilla?
Yeah, there was a gorilla in this video.
This video is from research by Daniel Simons and Christopher Chabris and is copyrighted.
So that was just an interesting video because many people don't see the gorilla, even though it just walks in, does a dance, and then leaves. Because their focus, their attention is on the people passing the balls in white. And so that's also a way that, if you're not focused on something, you may not be able to remember it or even notice it to begin with. Okay, so some takeaways: sensory memory, what it is, working memory, long-term memory. This is all part of the informational processing model. The lymphatic system, which is the, what is going to clear away those neurotoxins at nighttime. Acknowledgements to Dr. Paul Lewis and the IRC team. Thank you guys so much for listening to me. It's 1 p.m., so thank you. If you have any questions or want to meet me during my office hours, I have office hours on Thursdays at 9 p.m. EST. And if you want other office hours, just shoot me an email at oniechiowa@gmail.com. Okay, perfect. Thank you.
Thank you so much, Oni, for teaching us about memory health and how it connects to neurological disease and even everyday lifestyle choices. Thank you so much to all of our teaching fellows who taught you today. And I have one announcement for next Saturday. Next Saturday, we will be having a research conference day. And instead of running from our usual programming hours from 12 to 2 New York time, we will have our conference from 9 a.m. to 11:30 a.m. So again, the timing for next Saturday's programming is 9 to 11:30 a.m. New York City time. It's also in our announcements, and if you can't make it, you can fill out the absence form. We'll stick around for a few minutes if you have any more questions. Have a great week, everybody.